comes to suspicious cornea, thin cornea, of course we go to PRK than LASIK. But the question is, where is the limits and when we are going to stop considering PRK? When it comes to suspicious topography, it's a wide term with lots of area of gray zone when some surgeons can consider this as suspicious even for PRK. Others would consider this as safe. So yes, PRK is safer than LASIK, but still has limits. Does this is considered suspicious topography for others? It's okay for PRK for me, for example. What about this, or that one, or even this one? We all see, of course, in the practice now, some surgeons can do for this case such topography PRK with cross-linking, what called Athens protocol. So I will show you this case more or less as we see a normal topography with some skewing axis. It's a little bit suspicious. Patient has only -2 diopter with a relatively or definitely thin cornea, but the low error was so tempting for the surgeon to go and do PRK. The result was severe ectasia within few years that needs keratoplasty in both eyes. So still, when we push the limits in terms of corneal thickness, still we may get ectasia. So PRK is not 100% safeguard against ectasia. What about haze? Also, when we push the limits when it comes to refraction, it's not straightforward myopia. When we start to have a mixed astigmatism or cross-cylinder ablation with hyperopic ablation for correction of the surface ablation in suspicious topography, we still may have a severe haze that may end up by needs of keratoplasty. So this is the aim of my study. We studied the refractive outcome and safety of ICL and toric ICL implanted for myopia less than 4 diopter. We reported, those was on a consecutive eyes. We reported the visual outcome, manifest refractive spherical equivalent, the cylinder, the correct distant visual acuity in terms of safety, and reports of any complications. So this slide shows the results. We have 35 eyes enrolled in this study. At 1 year, 31 finished 1 year follow-up and 88% follow-up. We have average age of 26 years of the patients. We have 25 eyes implanted with spheric ICL and 15 implanted with toric ICL. As you see here, the manifest refractive spherical equivalent reduced from -3 down to -0.26 or 0.25. The sphere reduced from -2.8 down to almost plano. And the refractive cylinder still was doing fine. This scattered graph shows the predictability of the procedures. As you all see, the procedure was so predictable with a mild tendency to undercorrection. Safety. This 30 or 39% of the patients did not lose any lines or gained 1 line. There is no significant loss of corrected distant visual acuity. This 6% is on loss only 1 line, and as we all know, loss of 1 line is not clinically significant. Complications, we have just transient IOP rise in some patients. This is due to retained some visco materials. Actually, in my practice, what I do, I don't rely much on anti-glaucoma. We just, from the paracentesis from the second port of the wound, we can just, on the same day of the surgery, you can just press, evacuate some visco, and usually the patient doesn't need any more intervention than this. No cataract developed during the period of the study, over 1 year, and there is no other intraocular complications reported. So to conclude, ICL and toric ICL was found to be safe and very predictable for the correction of low myopia. So the take-home message, don't push the limits and consider ICL for correction of low myopia. Thank you very much for your attention.
Thank you, Dr. Ayman. Any questions?
We need mic there. The mic there. The mic is there.
I not agree with Dr. Ayman about this paper. Firstly, ICL procedure has many complications, cataract glaucoma, corneal decompensations, and others. This is the first. Second, in the evaluation, he depends on OBD scan only, where Pentacam and Bellin and Brezio and like this to exclude ectasia. This is the first notice. If you need ICL restricted to higher error, and even now higher error more safely with smile technique, up to 10 and 11 and even 12 diopter. Safely and very safe with smile technique if Pentacam measures allow. So you put the patient under these hazards and even a small degree for correction of a small degree of myopia, I not agree with you. Thank you.
The other point that I think it's very early to conclude that there is no cataract development in 1 year period. As we know that after ICL, it takes time. And this is just, it's very early to conclude there is no cataract formation after ICL by this study. Thank you.
Okay, I will have a comment for the first 3 points. As you mentioned, ICL as any intraocular surgery may have the complications as you mentioned. But really, let me tell you that cataract incidence after experience of thousands of patients does not exceed 1 to 2%. And this is not only my experience, it's the FDA study that this ICL earned the FDA approval based on 2003. So this is the first thing. Yes, there is, but the incidence is 1 to 3%. Cataract is a very benign complications when it comes to corneal ectasia, when it comes to corneal haze. Cataract, you can just go and take it out, and that's it. The other incidence of retinal detachment or endophthalmitis is a very, very quite rare, not exceeding cataract surgery, normal phaco. So the point is that the argument here is, shall we push the limits and do for a patient 460 microns, a -2, -3 ablation, because it's a PRK? Smile still doesn't have a role here. So this is my point. When it comes to a risky or gray zone, shall we push the limits and forget about phakic IOLs because our non-scientific actually believe that this is a hazardous? There is hundreds of published cases. There is an FDA study that confirms its safety. I agree with you, 1 year is not it's not a long term, but still after 5 days, the cumulative incidence of cataract does not, visual significant cataract does not exceed 3% in any of the published studies. In expert surgeons, maybe surgical trauma, this is a personal variance, you may have whatever complication, you can name it. This study was not meant to evaluate risk factors, to compare Pentacam or posterior float, what you meant, and OPD. I just showed in examples of corneal topographies that we may have different opinions about. I can see it suspicious, you may see it not. So this is personal variation. So this is my point I'm tackling here, that we don't have to consider this gray zone of science to build a knowledge on it. There is still other safe options. In high myopia, this is not the terms. High myopia, it's direct straight. For me, I don't do any laser more than -8, whatever, smile, any corneal refractive procedure, I don't do above 8. And also the why, I have many reasons. The first thing, when it comes to visual quality, there's lots of this. If we consider just safety, not to have cataract or not to have retinal detachment, there is a safety of losing corrected distance visual acuity, loss of contrast sensitivity, night problems. All this may happen definitely scientifically above 8. And this is the ectasia risk score above 8, still you are putting the patient risk of ectasia. I agree with the second question. Definitely, this study was not mentioned to follow up the long-term safety. It's a safety for 1 year. Cataract may develop at any stage, but still does not exceed the mentioned incidence. Thank you.
Prof. Tabara.
Dr. Ayman, I would like to congratulate you on your interest in trying to find a solution for our patients in Saudi Arabia that have very low myopia. But I would like to mention that and this is a good point that Dr. Al-Farhan was mentioning, that we are starting with a cosmetic procedure. This is not cataract. When we have cataract, there is a reason to intervene and there is a reason for surgery. But this is your choice and the patient's choice.
Definitely.
If it were my eye, I will not let you to touch me. And somebody with -2 and -3 will have perfect vision at 40. And, you know, life is not stationary. We have to go on. If you do it at the age of 30, then in 10 years, he will need a correction for reading. So there are risks and benefits for any procedure. And fortunately, in Saudi Arabia, we don't have mechanisms to approve such trials. And you are starting a trial in Saudi Arabia on normal patients who have low myopia. And I think that the Ministry of Health or the FDA should establish guidelines for clinical trials of this type, specifically for cosmetic procedures, such as very low myopia. I will not do it, even if it's 1 in 1,000 endophthalmitis. If you have a nasoplasty, would you ask if the doctor tells you you'll have 2% of dying under general anesthesia, would you go ahead and do a cosmetic procedure? You will never do it. So even if you have 1 in 10,000 or 1 in 1,000, I will not do a cosmetic procedure which is changing. So what I would like to see is maybe the Saudi Ophthalmological Society or some other organization will start with guidelines for our clinical trials, specifically for clinical trials on normal eyes that have very low myopia.
Thank you, Dr. Tabara, but this was not a clinical trial.